I want you to contrast that case. This is a man who came in a very exact onset. He was aphasic. He had lower facial weakness as well as arm weakness. And contrast that with this case. A 67-year-old male presents to the emergency department for slurred speech. He noticed the symptoms after waking up when he could not drink his coffee. The night before presenting, he noted that loud sounds were more bothersome. The patient's awake and alert. He's able to appropriately answer questions, though speech is slurred. On examination, there's weakness of the right upper and right lower face. Eye movements and the remainder of the examination are normal. Patient's blood pressure is 126/82 with a pulse of 65. He's not on any anticoagulant therapy. He has a normal PT-INR. Blood glucose is 98, and non-contrast head CT is interpreted as normal. Very similar to the last case. If you look this time, there's no aphasia, and the patient has upper and lower facial weakness. Which of the following treatments is the most appropriate? TPA, IV heparin, aspirin, low-dose prednisone or high-dose methylprednisolone. This is a case of Bell's palsy, and the best possible answer here is low-dose oral prednisone. For this case, the thing that you would be expected to recognize is that this is a simple Bell's palsy case and different than the stroke case. Right? And the best data we have is that simple prednisone may help reduce the severity of symptoms. Bell's palsy is an idiopathic dysfunction of the seventh cranial nerve. A key point here is that the lower motor neuron, or the facial nerve, supplies the upper and lower face. That's typically the giveaway that it's a Bell's palsy case versus a stroke. There is a specific brainstem case that we'll try to highlight as well. The facial nerve does supply the sapedius of the ear, which becomes disabled by the Bell's palsy. So patients oftentimes report hyperacusis. They'll say loud sounds really bother them in the day before their symptoms start. Patients may also report decreased taste. The chorda tympani is a branch of the facial nerve and supplies the anterior 2/3 of the tongue. If there is involvement of taste, the patient reports they cannot taste. That is a poor prognostic sign in terms of recovery. In terms of testing, no testing is required. The diagnosis is clinical. If an MRI scan is done, it may show enhancement of the seventh nerve. That is a normal finding in Bell's palsy, but testing isn't required. This can be made simply as a clinical diagnosis. In terms of treatment, oral steroids appear to be the most effective if given within the first 72 hours. Various doses are recommended from 25 milligrams twice daily to 60 milligrams for 5 days and then reduced, but there's no consensus statement, so simply giving low-dose steroids would be the appropriate answer. Adding an antiviral offers no significant benefit regarding facial recovery. A modest effect is possible, so adding an antiviral is considered a Class C recommendation by the American Academy of Neurology. For a specific syndrome, Ramsay-Hunt syndrome is facial palsy plus vesicles in the external auditory canal, tympanic membrane, or oropharynx. In those cases, an antiviral therapy should be included. In terms of prognosis, the majority of patients make complete recovery within 1 year. I wanted you to contrast that with the final case, and one that I think would be much more challenging. I think the first two cases are straightforward. Can you identify a very common type of stroke with aphasia and contralateral weakness? And a Bell's palsy case, which is a very bread and butter internal medicine and neurology case. I want you to contrast that with this case, which would be a more challenging case, but it does highlight an important neurologic point. A 67-year-old male presents to the emergency department for slurred speech. He noticed the symptoms after waking up when he could not drink his coffee. When it did not resolve 6 hours, he came to the emergency department. The patient is awake and alert. He's able to appropriately answer questions, though speech is slurred. On examination, there's weakness of the right upper and lower face. When asked to look to the right, neither eye moves. Eye movements in all the directions are normal, as is the remainder of the examination. Patient's blood pressure is 126/82 with a pulse of 65. He is not on any anticoagulant therapy and has a normal PT and INR. Blood glucose is 98. A non-contrast head CT is interpreted as normal. As you look at this case, and again, this would be a more challenging case, you see weakness of the upper and lower face, which make you think this is a simple Bell's palsy. But there's an important point here. The patient cannot look right. When asked to look right, neither eye turns to the right. So now I have right upper and lower facial weakness, and I have impairment of eye movements to the right. In terms of treatment options, what's the most appropriate? TPA, IV heparin, aspirin, low-dose oral prednisone, or high-dose intravenous methylprednisolone. The best answer here is C, aspirin. And what I would expect you to recognize that this is a common stroke syndrome. Again, I think this would be the more complicated of all the possible questions. The patient has evidence of a brainstem stroke affecting the 7th nerve and the 6th nerve. The patients are more than 6 hours old, so aspirin is the appropriate answer. The patient would be considered out of the window for TPA. Heparin isn't indicated for any form of stroke. Prednisone would be for Bell's palsy, methylprednisolone for an inflammatory lesion. This is, though I do not expect you to know, or I don't believe you'd be expected to know any significant amount of neuroanatomy, I do believe this is one important part. So there's a relationship between the 7th and the 6th nerve. The 7th nerve wraps around the 6th nerve before coming out. Patients with Bell's palsy, the 6th nerve is spared. Their eye movements are normal. Patients with a brainstem stroke, if the 7th nerve is affected, the 6th nerve is almost always affected. As a result, the patient can't turn their eyes to the side. Why do I like this question? It goes from answering a very simple case about Bell's palsy, where the treatment is steroids, and one simple examination finding: the eyes don't turn to the right. And I now have facial weakness on one side, my eyes don't turn. That means this piece of anatomy has to be involved, the 6th and the 7th. I've gone from a simple case, that patient can leave your clinic safely, they can leave the ER safely with just prednisone, to a more complex case. They've actually had a brainstem stroke. They need to undergo emergent evaluation for their stroke risk factors. Again, the simple finding: any patient who comes in for Bell's palsy, on the examination, the only thing I really care for is, do your eyes turn in the same direction as the weakness? If you've got facial weakness and the eyes turn, it's probably Bell's palsy. Facial weakness, the eyes don't turn, it's a brainstem stroke, more complex. For this patient, it's more than 6 hours old, so they're out of the window. The treatment here would be aspirin. I think this is a lower in terms of importance for the internal medicine examinations, but eye movements are listed as something you're expected to know. Again, I think low likelihood to be asked, but it's on the outline, so I included it. For the most part, everything that moves the eyes is the 3rd nerve. What turns your eye out is the 6th nerve, or the abducens, and what helps you look down and away is the 4th nerve, or the superior oblique muscle. So when in doubt, if you've got a question about an eye movement, guess 3rd nerve. The only other one is that the 6th nerve helps your eye turn out, and the 4th nerve is a complex nerve that isn't commonly asked. So if you have to guess on eye movements, guess 3rd nerve. I'm going to move on from stroke and stroke mimics to transient ischemic attacks and things that can mimic that as well. A 72-year-old female presents to the emergency room at 7:23 a.m. after developing painless right monocular vision loss. Symptoms lasted for 10 minutes. The patient described the symptoms as being like a lampshade closing over her eye. Her neurologic examination is normal. A non-contrast head CT is normal, as are all labs. What is the most appropriate diagnostic test of the available options? An EEG, bilateral carotid duplex ultrasound, a 4-vessel conventional angiogram, ocular coherence tomography, or an MRI scan of the orbit with and without contrast. Right, the patient's reporting 10 minutes of transient vision loss, and using a key word here, like a lampshade closing over my eye. So of the available options, a bilateral carotid duplex ultrasound is the best option. This patient has symptoms very classic for a TIA or amaurosis fugax. They give you that story of the lampshade being pulled over the eye for 10 minutes and resolving. That is highly consistent with a TIA coming from the carotid or anterior circulation. Though the symptoms are paroxysmal, they come and go, and EEG would be better for a seizure. There's nothing consistent with that here. There may be a role for an MRI scan, but the carotid ultrasound would have a bigger impact in terms of treatment, at least in my view. OCT is an interesting way to evaluate the retina specifically and used more for multiple sclerosis. A conventional angiogram would be, I think, more than what is necessary. It would have a larger lobe and looking for an aneurysm, whereas simple non-invasive carotid duplex would be more appropriate.